Good afternoon, everyone. I welcome you all to this special session of guest lecture, which is to be delivered by none other than Dr. Devi Prasad Shetty, who is chairman of Narayana Hridayalaya Limited. He is being with us since morning, and he has kindly acceded to our request to deliver this special lecture, which will be of benefit for all of us. Just to introduce the orator, Dr. Devi Prasad Shetty is a cardiac surgeon of repute and a successful entrepreneur. Dr. Shetty is a highly respected luminary for his ingenious ideas for reforms in healthcare sector. His visionary leadership to make quality healthcare affordable for all has drawn global recognition at international level. Narayana Hridayalaya, where he is working, has been an interesting case study for the likes of Harvard Business School and the Wall Street Journal. In association with Government of Karnataka, Dr. Shetty pioneered Yashaswini, a very inexpensive micro health insurance scheme benefiting more than 3.4 million rural poor. Dr. Shetty is the current chairman, Board of Governors, Indian Institute of Management, Bangalore. He is a member of Health Insurance Consultative Committee constituted by IRDAI. He has also served as a member, Board of Governors of Medical Council of India and representative of President of India in Board of Governors of IGNU. A strong advocate of technology for efficient healthcare delivery, Dr. Shetty takes deep interest in creating and developing software products and applications to achieve time and cost efficiency while minimizing clinical errors in healthcare delivery. Dr. Shetty also has a US patent registered as inventor. Dr. Shetty is the recipient of several prestigious awards, including the Padma Bhushan, Padma Shri, the Economics Innovation Award, Financial Times ArcelorMittal Boldness in Business Award, Nikkei Asia Prize for Economic and Business Innovation. He has also been awarded honorary doctorates from University of Minnesota and IIT Madras. Dr. Shetty is the founder and chairman at Narayana Hridayalaya Group of Hospitals. The group now has 47 healthcare facilities with close to 7,000 beds. So with these words, we welcome Dr. Devi Prasad Shetty for this guest lecture, and we are thankful to him for agreeing to our request. To begin the proceeding, I request our Honorable Director to formally welcome him with the bouquet of flowers, please. We have this presentation which is available on our AIIMS YouTube channel, telecasted live. So may I request Dr. Devi Prasad Shetty to please give us his wisdom.
I'm extremely grateful to the director, the faculty, the students for giving me an opportunity to interact with you. Can I project my slide? Can you? Okay. Okay. I believe India will become the first country in the world to dissociate healthcare from affluence. India will prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy. Now, I would like to ask you how long you think it will take for us to achieve this goal of rich or poor, whatever treatment they require, they will have it. How long do you think it's going to take? Is it going to take 10 years, 20 years, 30 years? It will happen within 5 years. Now, why do you think I'm so confident to give the time frame? We are a very interesting country. We have gone from no radio to color TV in less than 25 years. We have gone from no phone to the most modern mobile phone in 20 years. We defy all the logics. UPI was launched just before the COVID. Today, UPI is the largest financial platform in the world. We transact more transactions than China and US. So we are a very interesting country. We skip several phases of development. Now, the doctors, administrators here, how many of you have you heard of online diploma course in healthcare management from IIM Bangalore? How many of you have heard about it? Forget about enrolling. And how many of you think it is important for all the doctors to get the management lessons? How many of you think that it is important? It is very, very important for every doctor to learn the principles of management. First of all, I can tell you that if you have the knowledge and the wisdom to become a doctor, learning administration is no big deal. It's just that you have to understand that that is very, very important. Why that is important? It is important because we always look at the future as an extension of the past. We look at the future as an extension of today. Today, this hospital is running because government is funding the management. What guarantee is there that the government will continue to fund? There is no guarantee. So it is very, very important that every institution should be financially viable, because today giving something free to people, charity, is the worst thing what you can do, because charity is not scalable. Good business principles are scalable. According to me, the most respectable charitable organization in the country should be the mobile phone company. They have increased the revenue of working class people, almost doubled it, by charging what is a tiny, tiny percentage of what an American or a European mobile phone subscriber pays. And that is charity. And they are growing. It's not that they are losing money. They are running the services, very efficient services. They have transformed the lives of poor people. Today, look at the movies. In good old days, only people with money could watch the movies. Today, anybody can watch any movie which is shown anywhere in the world. And they made it happen. So, essentially, I would like all the young doctors to know that the best gift you can give it to people is a service at a price what they can afford. Now, we all are living in a world wherein we believe that the government has to give healthcare free of cost. We believe every citizen has the right to demand healthcare free of cost. And our governments continue to offer promise. But if you really look at the history of universal healthcare, which is free, there are three basic facts. First thing, only small countries can afford to offer universal healthcare. Big countries simply cannot offer. United States of America, richest country in the world, cannot offer free healthcare to the citizens. Forget about us. Then the countries which give free healthcare, they have a very high tax to GDP ratio. They have tax to GDP ratio of 45%. Invariably, they are more than 25%. And do you know what is the tax to GDP ratio of our country? It is 11.2%. With such a small taxpayer base, how are you going to give healthcare to 1.4 billion people? It is not possible. And the third fact, all these countries which are offering universal healthcare free, they spend 10% minimum of GDP on healthcare, minimum 10%. And our government is spending 1.2% of the GDP on healthcare. So, the most important thing is that we should change the national narrative. We have to tell our policymakers that let's not talk about universal free health care. Let's talk about universal health insurance. Then there is a hope. How that will work? Today you look at any working class population. They cannot afford to admit their loved ones to the hospital. One day of ICU care will cost 30,000, 40,000, which they don't have. But if you come up with a health insurance which is affordable, all of them will contribute. And that is what we should aim for. Government of Karnataka agreed to become the reinsurer. We network with 700 hospitals across the state. 4.5 million farmers became members. And at the end of 12, 13 years when we closed the scheme, nearly 1.5 million farmers had varieties of surgeries. More than 1.3 lakh farmers had a heart operation. All they paid was 5 rupees per month. When 100 people pay 5 rupees, nothing happens. But when 4 million people pay 5 rupees, amazing things happen. And this is the power we have in India. So we should really look at affordable health insurance program. Now, I run heart hospitals and we do large number of heart surgeries. 14% of the, approximately 14% of the heart surgery done in India is done by us. More people develop heart attack, it is better for us. We have absolutely no incentive to keep the people well. Because if the people are well, we lose our business. Now, look at the Indian scenario. We have major trust deficit in this industry. There are hospitals, there is insurance companies, and there are patients. 3 of the stakeholders. Hospitals do not trust the insurance companies. Insurance companies do not trust the hospitals. And patient doesn't trust both parties. So you have a business wherein there are 3 stakeholders, they don't trust each other. Now, look at the patient and the doctor, the hospital relationship. Because we get benefited by them falling sick, they don't trust us. So we need to look at a different model. The model is a managed care, which is promoted by Kaiser Permanente more than 60 years ago. Managed care is a different type of health insurance, wherein we collect a premium from the members in the beginning, and we work it is an insurance which is promoted by the hospitals. And we work very, very hard for 1 year to make sure that our members don't fall sick. Because if they fall sick, we lose money. If they are well, we save money. Then our interest and the patient interest is the same. If there is a diabetic, we will make sure that his diabetes is controlled. If there is a hypertensive, we make sure his hypertension is controlled. We advise people about the tobacco and all kinds of activity we do to make sure, and all the patients, we will screen them at the beginning of the scheme itself to detect early stage of cancer, early stage of heart disease, so we can control it. So in this model, we can dramatically change the way healthcare is delivered in the country. Now, this integrated health insurance, initially it should be offered for the missing middle. Missing middle is about 200, 300 million people who earn between 20,000 to 60,000 rupees per month. So, if you are offering a health insurance, it should cover primary care, preventive care, secondary and tertiary care. That is very important. Primary care is the most important component because 30% of the adults and the children, they consult the doctors at least twice a year. And it should be covering the entire family. There's no point in covering the man or the woman. We have to cover the entire family. And we believe for a middle class family to feel comfortable, for multiple admissions, they should be covered up to 10 lakh rupees. Multiple admission for it's a floater scheme for the family of father, mother and children. And single admission, say for a bone marrow transplant, heart and lung transplant, they should be covered for 50 lakh rupees. So there is no difference between what a working class person family can afford or a rich man's family can afford. Because nothing in this country costs more than 50 lakh rupees for a healthcare. Now, a lot of these families will have a problem in paying the premium in one go. So we should tie up with a fintech company wherein that fintech company will pay the money in advance, and over a period of 1 year, they can pay the money in installments. So it is like essentially a health insurance where you can pay the premium every month. Now, I want to ask you, what should be the premium for a working class family? To offer all these services, what should be the premium? Come on, I mean, guess any figure what you think they can afford to pay. Sorry? 500 rupees per month. ₹500 per year. Yeah. I just want to let you know that average Indian pays between 300 to 600 rupees per month just to speak on the mobile phone. Yeah. We believe if the premium is around, this is just we are just working on the figure. We believe a working class family can spare about 8,000 to 10,000 rupees per year. That is what they can. Whether the insurance will be viable or not, we don't know. But this is what we feel may be the viable figure. If we can deliver this, we would have transformed the India's healthcare. And this is possible. Now, why all this drama is required? Because on and off we read in the newspaper that, oh no, there are enough doctors, enough hospitals, why bother, everybody is getting the treatment. I will give you the hard data. India requires 65 million surgeries and India does 26 million surgeries. And in India, 32.6% of all the deaths are due to lack of access to safe surgery. 32% of the Indian population die because they do not have access to safe surgery. Now, you must be thinking, this must be heart operation or a brain operation. No. These are the three bellwether procedures. That is, emergency cesarean section for obstructed delivery, emergency laparotomy for appendicitis, and a surgery for compound fracture. If we have these facilities available at every level, starting from community health centers, we would have saved most of these 32% of the untimely death of breadwinners of the family. And why this happens? This happens because our policymakers throughout the history of this country after independence, healthcare is built around, all the policies are built around infectious diseases and medical treatment. Malaria, TB and HIV across the world kills 3 million people, 3.5 million people. But lack of access to safe surgery in India kills 32% of the deaths. Now, I have scanned the medical documents, all the policy documents of India, Malaysia, all the different countries. No healthcare policy document talks about surgery as the priority of the healthcare anywhere. Surgery is not a priority. If the hospitals are designed for the surgery, if the healthcare is designed around infection, this hospital cannot, or a medical treatment, it cannot do the surgery. But if the hospitals are designed to do the surgeries, then that hospital can take care of malaria, TB and HIV virtually free. We have to change the narrative. And this has to be done, and that will only happen if somebody is paying for the surgery. And the whole idea of the insurance is to promote surgical intervention. So large number of hospitals will come up, hospital will be viable. In turn, they will take care of medical problem. In turn, they also take care of the preventive and primary care. So we need to change the narrative. Now, for the transformation of the Indian healthcare to happen, we need to build a very, very robust digital platform. In digital platform, what we are talking about is digital health version 2. The digital health version 1 was we replaced the paper with the digital tool. The version 2 is a smart, interactive digital platform built on a mobile platform. Why mobile platform? Because doctors look at the desktop or a laptop just 5 to 6 times in a day, but they look at the mobile phone 200 times in a day. Why digitize at all? What is the great benefit of digitizing healthcare? The greatest benefit is safety. We think that patient is very safe in the hospital. Patient is not safe in the hospitals. American hospitals are perhaps the safest hospitals on the planet. If 200 patients spend just one night in an American hospital, 1 in 200 dies due to medical error, not medical negligence, medical error. Getting admitted to an American hospital is 10 times riskier than skydiving. Now, there is a study published by BMJ that medical error is the 3rd leading cause of death in the US. Medical error. Why medical error happens? This is the study by Joint Commission of US. 65% of the sentinel events happening in the hospital are due to communication failure. What is communication failure? 5 o'clock in the evening, blood culture becomes positive, and the report has to be printed and it has to go to the ward, and the report goes to the ward. By the time doctor on duty has gone, somebody else who has come, he is not going to look at what was the blood culture report, and next day morning by 9 o'clock somebody sees the report that this streptococcus viridis, whatever the deadly bacteria is causing the sepsis, it's already too late. Now, if you have a simple digital tool wherein all these machines are linked with an application which is working on a mobile phone, the message will reach all the 20, 30 doctors in that group and you can save the life. So, the main reason why we should go for digital technology is to reduce the mortality, morbidity in the hospital. We believe that the smart software will make ordinary doctors extraordinary and extraordinary doctors into path breakers of innovative therapies. This is what will happen. Within the next 5 to 7 years, smart software will make smarter diagnosis than the doctors. And within a short period of time, it will become legally mandatory for the doctors to get the second opinion from the software before starting the treatment. It will happen. That will not make doctors less important. That will make us safer for the patient. That will make us more productive for the patients. Now, why do I say that the smart software will make smarter diagnosis than the doctors? If you have a software, if you have a doctor who has got whole day to diagnose one patient, he can beat any software. But if you have 5 minutes to 8 minutes in your outpatient to diagnose the problem, smart software definitely will be smarter. I'll give you the reason. Everything in the horizon of the doctor's memory and our analytical skill of our own brain, there are only 2,445 diseases one can suffer from. There are about 30,000 diseases. All these diseases are diagnosed by the machines, not by doctors. A doctor in the clinic, he can only, the common diseases are only 2,445. How do we diagnose it? We go by the symptoms. Irrespective of how fussy your patient is, there are only 638 symptoms they can complain about. And when you examine, there are only 510 signs. There are only 2,245 lab test reports, and there are 426 imaging reports. So you have to match these things for the 2,445 diseases. And a simple software in your mobile phone can do it. Now, what is the beauty of technology? The beauty of technology is that it will restore the joy of healing. Today, we doctors have stopped enjoying treating patients. We are constantly under the fear of making mistakes. That wasn't the case with my teachers, because my teachers had very few data points to diagnose. They talked to the patient, they saw the X-ray, some blood test report, and they diagnosed. Today, when I see a heart patient, he has minimum of 500 data points coming from all over the place. Human mind cannot decipher that much of data and always come up with the right answer. Now, I will talk about restoring the joy of taking care of the patient. Let's look at a nurse working in your ward or my ward or a ward in US. What is the job of a nurse? If you ask whether she is happy working in the ward, most nurses who are honest will say they are not happy. Why they are not happy? They start their job at work at 7 o'clock in the morning. They take one BP apparatus. They go from one patient to the other. They check the blood pressure, temperature, respiratory rate, and they enter all those things into the chart. It takes about 10 minutes. Then they go to the next patient and the next patient. If there are 30 patients, by the time they finish 30 patients, it's a time for them to do it all over again. It is the most boring, mundane job. There is no intellectual stimulus to do that work. But the worst thing is, 2 o'clock at night, when they go to check the blood pressure and the temperature of the patient, the moment she touches the patient, first reaction is, the patient will scream at the nurse because she has woken him up and he can't go back to sleep again. And it happens in India, it happens in US, all over the world. So what do the poor nurses do? If they don't write the data, enter the data, next day she will be punished. So they bluff. They bluff in India, they bluff in US, they bluff in England. When I used to do on-call duties in England, most of the cardiac arrests used to happen between 4 o'clock and 6 o'clock in the morning because the patient is not monitored. We created a system to force conscientious healthcare workers to bluff, lie. Is it really required? We have simple tool. We are working now with a US company. They have a very simple patch. You put the patch and that patch will give continuous ECG. it gives the temperature, it gives restlessness of the patient, it gives the saturation, blood pressure, everything comes. And the data is analyzed by our analytic tool. And in front of the nurse's station, you can see that in front of the nurse's station, there are TVs which will constantly display the risk score. And nurses are told that you don't need to go near the bedside anymore. Don't do the rounds. Only when the color changes from green to orange or red, you go there and examine the patient. Then it is intellectually stimulating for them to go. And we always hear about a sudden cardiac arrest, more so in our heart hospitals. We have a hospital with over 600 beds. And every other day, a patient who was expected to go home in the morning, 10 o'clock at night, they go to the toilet or something happens. Suddenly, next day morning, they say, sir, this patient had a sudden cardiac arrest. I've been in this business for more than 35 years. There is no sudden cardiac arrest. Before the cardiac arrest happens, at least 6 to 10 hours earlier, patient becomes restless. Heart rate starts going up. Peripheral temperature starts going down. Oxygen, blood pressure starts coming down. And all these subtle changes happening, a nurse doing the rounds cannot pick it up. Whereas the machines can do it because machines don't get tired. So once we introduce this system, which we hope within the next 2 to 3 months we'll do it, I can almost guarantee that a sudden cardiac arrest will not happen in the ward. We can eliminate sudden cardiac arrest. The moment the risk score goes up, either you address it or shift the patient to the ICU. And even if the cardiac arrest happens, it happens in a controlled environment. This is the beauty of technology, what it can do in virtually eliminating sudden cardiac arrest. Now, about the intensive care unit. We believe that in the near future, most of the beds in the hospital will be critical care beds. Ward and room beds are going to disappear. A 85-year-old man who develops pneumonia, very sick, comes to the ICU directly. He gets treated for 3 days or 4 days. From ICU, they will get discharged home. And they will be monitored online by the doctors in the hospital. There will not be a need for a ward and room bed. That means, imagine a situation wherein 90% of the hospital beds are ICU beds. How many intensivists we need? And intensivist job is not very attractive for the young doctors. Young, bright doctors don't want to become intern because they need to do night duties. So how do you build large-scale ICUs without intensivist? It is possible. We would like to tell the intensivist that you work between 9 to 5, like any other doctor. After 5 o'clock, you can go home and give us 2 hours 3 times a week, after 5 o'clock and before in the evening and before 8 o'clock in the morning. So you have multiple doctors who are covering only 2 hours. That 2 hours, they sit in their drawing room in front of a laptop with all the data coming for 20 or 30 patients with the risk score. Today, when we look at the chart, you have temperature, blood pressure, central venous pressure, all these parameters. There will be another parameter, that is a risk score. And how it will happen, a patient who had a bypass comes to the ICU with a risk score of 2% or 4%. Within 4 hours, the risk score goes up to 10. Then when you tap 10, you get the reason why the risk score has gone up. So CVP has gone up, urine output has come down, whatever. Then the on-call doctor has to address these issues. So the ICU at night will be covered by mainly anesthetists put central line, arterial line, adjust the ventilator. Thinking intensivist will be at home. Imagine an intensivist who didn't sleep whole night at 4 o'clock in the morning, his capacity to think, and an intensivist who slept whole night and got up at 4 o'clock in the morning at home, sitting in the drawing room with a cup of tea, he is in a much better position to understand. And this is possible. And when this happens, you don't need to have a doctor based in your own city. He can be based anywhere in the world. So this is the way ICU will happen. For that to happen, we need to have a very, very strong digital platform. So in the end, this is my last slide. I just want to remind you that the Uber, world's largest transport company, doesn't own taxis. Facebook, world's largest media company, doesn't create any contents. Alibaba, world's largest retail company, has no inventory, and Airbnb doesn't own any real estate. And the world's largest healthcare providers will be the softwares. They have no beds. And this is the way technology will disrupt our industry. And sooner we embrace the change, it is better for us. Thank you so much for the opportunity.
Thank you, sir. We don't have question and answer session routinely in these sort of a guest lecture. So to bring the curtain down to the proceeding, I request our Honorable Director to felicitate the guest of the day, Dr. Devi Prasad Shetty. Please. So, to bring the proceedings at the closer, I am thankful to our Honorable Director who has given this opportunity to have a talk from one of the pioneer in cardiothoracic sciences, Professor Devi Prasad Shetty, who is being with us. We are also thankful to Dr. Devi Prasad Shetty for agreeing our request to deliver this lecture today, which has basically given us some sort of words of wisdom and food for thought in future healthcare system which is going to come in India. I'm also thankful to all the faculty members, all students, residents, and all other staff members who are there with us for being with us in this entire presentation. Thank you very much. And now I request all of you to join us for the cup of tea in the boardroom, please.